Our speaker is Tony Borrell, and he's going to be talking on a comprehensive new paradigm for prenatal diagnosis.
Thank you very much. First of all, I would apologize that yesterday morning I was not able to welcome every one of you here to the town, to Barcelona. And probably the people who were here last year, I mean, in the previous course, they found that, I mean, the town has changed a lot. So we have a profound impact with the attack of 3 weeks ago. So it was a very sad city after that. And more than anger, it was sadness. And we are in troubled times. In 2 weeks' time, there will be a big political event. So definitely this will be at times of changing here in Barcelona. And if you want to come again in 2 weeks' time, you will be very welcome to come. So sorry for saying welcome when maybe most of you are almost leaving now, but if you stay longer here in the town, this week is starting the annual festival, so there will be a lot of activities going on, mainly on next weekend. Okay, so let's change. Let's go to what I was trying to present. When I started to do prenatal diagnosis, I mean, almost the first day, there was a clinical geneticist that say, look, this is the essential medical genetics. Take this book and you have to learn by heart everything in that book. And in this book, they classified the birth defects, fantastic, not very basic, but a fantastic book. And the birth defects were classified in chromosomal anomalies, almost 1%, monogenic disorders, 1%, and structural anomalies, 3.7%. After that, I learned properly genetics in Boston with another book, Thompson & Thompson, and tougher than the other. And here there was something they have changed, 10% copy number variance. So like a new kind, I was already know the contiguous gene anomalies, but here was separately as a different condition. So now I've tried to present to pregnant women all birth defects in a clear fashion, and I've done this diagram. I don't know if you will like this. Fetal structural anomalies are very common, 3%. Mostly of them are of multifactorial origin. And then there are the genetic anomalies, chromosomal anomalies, microscopic chromosomal anomalies, about 1%, a little bit less. Submicroscopic anomalies, about 1%, a little bit more. And single gene disorders, let's say 1%. Very difficult to say. And maybe after drawing this, I changed my drawing and say, look, because there are some structural anomalies also going with chromosomal anomalies, and the cause were really a genetic cause. So this was my final diagram that I'm showing to pregnant women. And my idea is to have half an hour and to go with detail to all these items. Peter, you have shown this morning that prenatal diagnosis birth defect started with Down syndrome, because maybe the most important cause of intellectual disability, and with neural tube defects, because they were probably the most important structural anomaly in the Anglo-Saxon population or in the Western population on that time. So prevalence of Down syndrome has been going up from 1 in 700 to 1 in 450. This is EuroCat. You know that EuroCat is all the population registries of Europe. So this is not the data coming from particular very specialized hospitals, but from the general population from these registries. So now in Europe, this is the prevalence of Down syndrome. And neural tube defects now in Europe is 1 in 1,000, and some years before or some decades before was much higher than this. Screening started with asking which is your age. So if you were more than 35 years, you were high risk for Down syndrome, and doing maternal serum alpha protein to check the risk of spina bifida, and later on looking at these intracranial signs of neural tube defect. And prenatal diagnosis was based on amnio plus karyotype for Down syndrome, and at the beginning also an amnio, an amniotic fluid alpha-fetoprotein, and later on directly on scan. So let's go point by point. How is prenatal diagnosis organized, and how has it evolved in the last years, and how it may evolve in the future? So these are structural anomalies in Europe, 2.4, just major structural anomalies, which is the percentage that are prenatally detected or diagnosed. The overall percentage is 39, let's say 40%. Nowadays, it's really low, but there are some anomalies, 99, 89, so anencephalus, spina bifida, very good figures, 89% detection, prenatal detection. These are the data from the registry of Barcelona. So again, it's not our hospital, it's not a particular hospital, it's all the births in Barcelona. 40% are the care is private, so it's not exactly the same that in the big hospitals. And this registry stopped at 2006, so we have still 10 years that we don't know, but we can extrapolate. So one of the characteristics of ultrasound evolution and ultrasound diagnosis is that it has been evolving constantly, steadily, with the same, from every year, ultrasound examination is a little bit better than the previous year, but there has not been a big revolution in ultrasound diagnosis. Just completely what happened in genetic prenatal diagnosis. So it's a very steadily increase year by year. And here is the detection before 24 weeks. It was 20% on 92. It was 50% 2006, and I can extrapolate that now is 60%. And this is late detection, 20% extra, more or less, going to 80%. And I think that nowadays in the city of Barcelona, we detect 80% of major structural anomalies. And this is what not happened in our hospital, that, our results are much better. We are a very specialized center on this. And I take some data from the last decade, from 2002 to 2009, and on those years we detect half, 49%, of the major structural anomalies in the first trimester, 30% in the second, 15% in the third, and 6% when undetected. Obviously, this is not the same in the different systems, and the best was this is digestive and abdominal wall. And skeletal, also more than 50%, heart 50%, other 50% in the first trimester, Central nervous system 15%, facial and urinary less than 50% in the first trimester. When we find an anomaly and a routine scan, this is an incidental finding. When we find a hydrocephaly, when we find a cleft lip, when we find a diaphragmatic hernia, when we find a multicystic kidney, when we find a spina bifida or a skeletal dysplasia, in routine scanning, all the findings are incidental findings. Nothing is related with the previous pathology that we're looking for. I'm trying to do some correlation between genetic, as you can imagine, with the ultrasound diagnosis. Incidental findings, everyone here knows what is this. Finding or diagnosing hepatic metastasis when we are doing an MRI for back pain, finding a trisomy 21 when we do a study for tuberous sclerosis, Charcot-Marie-Tooth. But these are all findings where you are doing an ultrasound scan. That MFM doctors, we are dealing every year with more than ultrasound finding, and pregnant women are used to that. Also, ultrasound examination, we have a lot of uncertain findings. We have some benign findings, for example, VSD, which is muscular. This is a benign finding. There are some pathogenic findings, the same VSD when it's perimembranous, and there are a lot of uncertain findings. For example, a genesis of the corpus callosum, mild ventriculomegaly, a dominant right heart, an ARSA, aberrant right subclavian artery. We are dealing every day with uncertain findings, uncertain significant findings in ultrasound diagnosis. Okay, let's move to the next category, chromosomal anomalies. This is the detection in Europe, in the population in Europe, 72%. The prenatal detection, 73%, sorry. And in Down syndrome is 69%, around 70%, are really good figures. This is the conventional screening, combined. We were the first centers to suggest to do biochemistry at 10 and nuchal translucency at 12, and finally this has been shown to be the best strategy for the combined test. The detection, this is a very robust test with the detection of, this is a systematic review that we did, 89%. Now is a recent CoGEN review, a systematic review, meta-analysis, 87% detection rate of trisomy 21 for a 5% false positive rate. We are used to this. I think we have achieved in most of the centers to have this. This is a table that I give to patients when we have to discuss about the screening. We do the combined test, still we are doing the combined test as the routine method, and when they have a risk that it's not high risk but very close to the limits, I discuss with them the different methods and if they want to do something else. Obviously, the combined test is being replaced by a new method, which is cell-free DNA testing. And now we are in a position that we have a lot of meta-analysis. We have 4, actually. Most of them are from UK. This is from UK. This is UK and Spain. This is Sweden, and this is UK also. And I will take some figures from 2 of them, mainly from the Taylor and Phillips meta-analysis, because it's doing a stratified analysis that I think is really interesting. So if we go through the effectiveness of cell-free DNA, the detection rate, everyone knows that for trisomy 21 is 21 plus. For trisomy 18 in these reviews, 97 and 97, and the false positive rate, everyone agrees, 0.1% for each of these trisomies. But this is the stratified analysis that I think is particularly interesting. There are 37 studies, but from the first trimester there are only 7. And done in the general population there are only 6. And done with consecutive cases, only 5. And the figures, if we analyze just these studies, change a little bit, from 99 to 96, 96 and 93. Obviously, these are a review of the old papers, and obviously the figures have been improving a little bit. So maybe this is not the exact real situation of today, but still there is a big difference, and still there is another point that they have not analyzed, and I would suggest somebody to analyze the papers with the full outcome, because for combined tests, it was not entered in a systematic review, a paper that don't have a full outcome, 99% of the cases followed. And most of the cases with cell-free DNA, they have 60% follow-up, 30% follow-up, so how they assume that the cases that are normal, they don't notify the center they are normal, which is not true. Had been shown that it's not true. So still, I think we need another column here saying full outcome. For trisomy 18, it goes down also, 97, 92, 86, 86, 97, 85. So definitely very low figures. The second issue that we have to discuss with cell-free DNA is the failed results. I started to say 3 years ago or 4 years ago that a failed result is a screen positive for me as a clinician. And now that I know that ACOG is suggesting that a failed result is a positive screening. Why? Because they have 3% risk of an aneuploidy. This is maybe more updated meta-analysis. The figures go down, maybe they have half in these years. So nowadays we can say that there are 2% of inadequate samples that they are not analyzed by the lab. They just repeat the sample. And there are 2.5% of the samples that the lab are considering fine to be analyzed that we got a failure to get a result. Half of them due to a low fetal fraction. And we know by a couple of papers that those cases have a 3 to 4% risk of aneuploidy and triploidy also. These are a detail of those figures. So, if we adjusted these figures, and we say these are the detection rate, but if you do as a primary analysis in the general population, these are the detection rates, and these are the false positive rates that already this meta-analysis has used failed results, has added to the false positive. So these figures, we can conclude that these figures are definitely better than the combined test, but that not 99.9% by a 0.001% that has been claimed. So this is the whole story, and I think it has to be told also, and this has been the untold story of the cell-free DNA, of the irregular implementation process of cell-free DNA. Effectiveness of cell-free DNA for sex aneuploidies is not so good. This is the meta-analysis, 90% for monosomy X, maybe now is a little bit better, 0.2% false positive rate. Another sex aneuploidies is 93, for a 0.1% false positive rate. If we add all the false positive rates for all the autosomal trisomies, it goes up to 0.7%. There have been a talk on microdeletion detection by cell-free DNA. These are the microdeletions that are offered nowadays here in Barcelona, in Spain, and there are for the different commercial houses, and usually there are 5 or 6 that they are offered. So I would like to summarize cell-free DNA, which anomaly should be detected. Trisomy 21, we admit, this is the best method to screen for trisomy 21, no doubt on this. For trisomies 18 and 13 is the good screening method. Might be similar than combined plus ultrasound, but definitely is a good method. For sex aneuploidies, which is the point? Well, we've been discussing that maybe Klinefelter definitely is useful, and for Turner syndrome, the most important cases are seen by ultrasound. But definitely we can discuss this. Probably I would be not so taxative as here. For microdeletion, I have to change a little bit, not validated that except for SNP method. In which population should be applied, in my opinion, to the cell-free DNA? Or the opinion of most of the guidelines, not to the very high-risk population. When you see an ultrasound anomaly, definitely is not indicated. You can be using high risk as a secondary screening. It can be used in the general population as a primary screening, and it can be used as a contingent screening in intermediate risk. For example, 1 to 100 to 1 in 1,000. As a secondary screening, which is the main advantage? The main advantage is avoid iatrogenesis of the invasive procedures. The point is that the iatrogenesis of invasive procedures, in many papers, is quoted as 1%, because this is what happened in the 80s. On the 80s, when you did an amniocentesis, you even saw the fetus. It was very hard. I started at the late 80s, but I saw the paper of the 1% was the early 80s, and I see some scans of the early 80s, and you saw almost anything at all at the scan, really, just the heart beating and something else. So it's logic that this 1% is not applicable today, and today the rate is this. So if you use the latest data, please use the latest data for everything, not only for one side. As a primary screening has been started in a population basis in Holland for the last 3 or 4 months. Still, we don't know some results. And also for the last month in Belgium. As a contingent screening, there are some different strategies. The strategy in Denmark is 3 branches, high risk, well, still I think there were 1 in 10. No, this was in Finland, sorry. This is in Denmark. Higher than 1 in 300, the women can choose between invasive or cell-free DNA. Intermediate risk, cell-free DNA is offered, or low risk, nothing is offered, any further test. And there is this contingent screening which is applied in Switzerland in 4 branches, very high risk. They only offer invasive procedures. This is very high. This is high risk. Women can choose between invasive and cell-free DNA. Intermediate risk, cell-free DNA, and less than 1 in 1,000, no further tests are offered. This is the picture in Europe. I don't know if in any country I'm not updated. So there are 3 countries, they offer cell-free DNA as a secondary screening. UK is starting on January 2018. 2 countries, they are using cell-free DNA as a primary screening. In Netherlands with the co-payment of 175 euros. I think in Belgium you have to pay 8 euros. And 1 country in which the contingent test is offered. In the other countries, there are some plans to develop it, and probably next year the picture will be completely different. One thing must to be taken into account, that we are talking about trisomy 21, obviously is the most common chromosomal anomaly. It accounts for half of the chromosomal anomalies. There are trisomy 13, 18, and monosomy X. We account for maybe another 25%, but there is, which are the typical chromosomal anomalies, but there is still about 20% of atypical anomalies that are not studied using standard cell-free DNA. Routine karyotyping, I agree with Tihang that there is no guide recommending routine karyotyping in pregnancy loss. However, my opinion is just the opposite, that it should do. I mean, it's very important to do pathology studies because we have to diagnose idatiform moles and exclude ectopic pregnancies. Karyotyping is not recommended, although it may reveal the cause in more than 50% of the cases. I mean, women ask, why does it happen? What did it happen to me? Say, obviously, it's a chromosomal anomaly. The nature is very wide. So, I mean, if there is a way to know it, and it's not a very expensive way, why don't do it? With the new methods and some changes we can do with molecular techniques, or otherwise we can do with CBS, what we do in our center. Also, the next question is, would it happen again? And the recurrent risk can be established with a previous karyotype. And I say that the obstetricians have a paradoxical thinking that you must do a karyotyping in a stillbirth. It's very important. Please don't forget to do a karyotype because you are fired in an obstetric department in a stillbirth, when chromosomal anomalies are not common. And when they are common, is not the current practice. So I cannot understand this reasoning. And also, it may reduce anxiety and help the grieving process, because although obstetricians are not very aware of this, a first trimester pregnancy loss has a very profound impact on the psychology, and I have 50% of anxiety disorders and 15% of other disorders also. These are the latest. So it is true that, I mean, the success rate of POCs was very low because of contamination, because of contamination with bacteria, contamination of maternal cells. But we've been doing CBSs, offering CBSs. In any miscarriage in our department, we say, do you want to know the reason? Do you want to do under the recurrent risk? Yes, yes. Do you want to do a CBS before evacuation? Yes or no? I mean, 80% or more than 80% of women say, yes, I want to know. So let's do a CBS. And we have a 90% cytogenetic success rate. Classical cytogenetics.
Tony,
So, yes.
we're getting a little bit late.
Well, next condition, microdeletions. These are the established indications. The problem with uncertain significant findings. Let's skip this and summarize just with the open questions. Array CGH or SNP array, so maybe it's better SNP array. Resolution, low height, maybe better high resolution. Parental samples, ideal but impractical. Triploidies undetected. If we do a QF PCR, we can detect triploidies. Balance anomalies undetected. Is it irrelevant? Probably it is. Reporting bows. Generally, we don't report bows in microarrays, except in ultrasound anomalies. We discuss each case. Replacing karyotype in all invasive procedures. They have already done in many centers. And universal offer. Why? Because we know that in the general population, there is more than 1% of pathogenic CMVs. And finally, the last condition, single gene disorders, have already been dealt with this by Jim very clearly. But maybe here in Barcelona we don't have data. There were very few data of Southern Europeans in those North American data. And these are the most common recessive conditions here. And for me, it appears logical to offer to offer carrier screening for those most prevalent conditions in each population. And finally, whole exome sequencing, that may be the new diagnostic method in structural malformations. Just this is to explain the problems with diagnosing monogenic disorders in abnormal cases. There was a lissencephaly in a female fetus at 28 weeks, normal QF PCR, normal CMA, so Miller-Dicker syndrome was ruled out, TOP. We decided to sequence at least one. It was a female fetus, no variant. Second pregnancy, 6 months later, another lissencephaly suspected at 22, confirmed at 28. Termination. We ordered a panel. We were discussing, it's better panel, it's better WES. Panel with 24 genes normal, MLPA for all the 5 genes correct, WES, whole exome sequencing, and we found 2 likely pathogenic alterations in ASPM gene associated to microcephaly with simplified Garel pattern. Simplified Garel pattern means lissencephaly. But unfortunately, because panels are housemate, this gene was in the microcephaly panel, but not in the lissencephaly panel. So to finish with, I think that the time has come to offer in the general pregnant population, first and second trimester anomaly surveys, to offer an haploid screening, cell-free DNA better than combined tests, obviously, and invasive diagnostic testing in positive cases, also karyotyping in pregnancy losses. About submicroscopic changes, I think that the 1.2% risk in the general population means that we should offer this in invasive procedures nowadays, cell-free DNA method in some years in the future to diagnose submicroscopic anomalies, and also carrier screening, preferentially preconceptional, and NGS panel and WES in malformed fetuses. It's obvious that we need a lot of education, we need a lot of time to spend with pregnant women, we need a lot of money to offer all this. But definitely As an obstetrician, I feel that I have to empower pregnant women to take their own decisions and the couples to assist in their decisions. Thank you very much.